Welcome to Pediatric Case Review. Today's presentation provides an in-depth clinical review of hereditary spherocytosis, covering pathophysiology, genetic basis, clinical manifestations, diagnostic approach, and management strategies. This lecture is designed for practicing physicians seeking advanced understanding of this hematologic disorder. Let's begin with a question about the epidemiology of hereditary spherocytosis. Which population has the highest prevalence of hereditary spherocytosis? Is it A. East Asian populations, B. African populations, C. North European and Caucasian populations, or D. South American populations? The correct answer is C. Hereditary spherocytosis predominantly affects individuals of Northern European and Caucasian descent, with an estimated prevalence of 1 in 2,000 to 5,000 individuals. It's much less common in other ethnic groups. The condition follows autosomal dominant inheritance in approximately 75% of cases, with the remainder showing autosomal recessive or de novo mutations. Moving to the genetic basis of this condition. Which protein abnormality is most commonly responsible for hereditary spherocytosis? A. Spectrin deficiency, B. Ankyrin deficiency, C. Band 3 deficiency, or D. Protein 4.2 deficiency. The correct answer is B. Ankyrin deficiency accounts for 50 to 60% of hereditary spherocytosis cases, making it the most common molecular defect. Spectrin deficiency accounts for approximately 25%, band 3 deficiency for 15%, and protein 4.2 deficiency for less than 5% of cases. These proteins are crucial components of the red blood cell membrane skeleton. Let's examine the pathophysiology of hereditary spherocytosis. What is the primary pathophysiologic mechanism in this condition? A. Increased red blood cell hemolysis in the bone marrow. B. Decreased red blood cell production in the bone marrow. C. Loss of membrane surface area leading to splenic sequestration. Or D. Primary autoimmune destruction of red blood cells. The correct answer is C. In hereditary spherocytosis, abnormalities in the red blood cell membrane proteins, primarily spectrin and ankyrin, lead to uncoupling of the lipid bilayer from the cytoskeleton. This results in loss of membrane surface area while cell volume remains unchanged, creating spherical red blood cells with reduced deformability. These spherocytes become trapped in the splenic sinusoids and are prematurely destroyed, resulting in hemolytic anemia. Let's consider a clinical case. A 6-year-old girl presents with fatigue, intermittent jaundice, and splenomegaly. Her father had his gallbladder and spleen removed in childhood. Which additional finding would be most suggestive of hereditary spherocytosis? A. Microcytic hypochromic anemia. B. Thrombocytosis. C. Reticulocytosis with normal NCV. Or D. Leukopenia. The correct answer is C. Patients with hereditary spherocytosis typically present with normocytic normochromic anemia accompanied by reticulocytosis, reflecting the bone marrow's compensatory response to hemolysis. This child's clinical picture is classic for hereditary spherocytosis, with the family history of splenectomy and cholecystectomy strongly supporting a hereditary hemolytic disorder. Patients typically appear well but may have pallor, mild jaundice, and splenomegaly on examination. Considering the physical examination findings in hereditary spherocytosis, which physical examination finding is least likely in a patient with untreated hereditary spherocytosis? A. Pallor, B. Splenomegaly, C. Mild jaundice, or D. Petechiae and ecchymosis. The correct answer is D. Petechiae and ecchymosis are not characteristic findings in hereditary spherocytosis. These would suggest a platelet disorder or vascular fragility, which are not features of this condition. On physical examination, patients with hereditary spherocytosis typically appear well but may demonstrate pallor due to anemia, mild jaundice from increased bilirubin production, and splenomegaly due to sequestration of abnormal red blood cells. After splenectomy, surgical scars would be visible. Moving to laboratory findings. Which laboratory finding is most characteristic of hereditary spherocytosis? A. Microcytic hypochromic anemia with low respiratory count. B. normocytic normochromic anemia with reticulocytosis, C. macrocytic anemia with normal respiratory count, or D. pancytopenia with myeloid precursors? The correct answer is B. Hereditary spherocytosis typically presents with normocytic normochromic anemia accompanied by reticulocytosis, reflecting the bone marrow's compensatory response to hemolysis. The blood film characteristically shows anisocytosis, poikilocytosis, and spherocytes. There may also be nucleated red blood cells in severe cases. Indirect hyperbilirubinemia is common due to increased red cell destruction. During aplastic crises, usually triggered by Parvovirus B19 infection, pancytopenia may develop temporarily. Here's a case-based question about peripheral blood smear findings. A 4-year-old boy with suspected hemolytic anemia has a blood smear showing numerous dense, round erythrocytes without central pallor. Which diagnosis is most likely? A. Hereditary spherocytosis, B. Beta thalassemia, C. Iron deficiency anemia, or D. Sickle cell anemia? The correct answer is A. The blood smear description is classic for hereditary spherocytosis, which is characterized by spherocytes, dense, hyperchromic, round red cells that lack central pallor. Beta thalassemia shows microcytic hypochromic cells with basophilic stippling and target cells. Iron deficiency anemia presents with hypochromic microcytic cells. Sickle cell anemia demonstrates characteristic sickle-shaped cells. In hereditary spherocytosis, anisocytosis and poikilocytosis may also be present along with the pathognomonic spherocytes. Let's discuss diagnostic testing for hereditary spherocytosis. Which test is considered the gold standard for diagnosing hereditary spherocytosis? A. Direct Coombs test, B. Osmotic fragility test, C. EMA binding test, or D. Genetic sequencing? The correct answer is C. The Eosin 5-maleimide binding test has largely replaced the osmotic fragility test as the gold standard diagnostic test for hereditary spherocytosis due to its high sensitivity and specificity. This flow cytometry-based test measures the binding of the fluorescent dye Eosin 5-maleimide to band 3 protein and is reduced in hereditary spherocytosis. While genetic testing can identify specific mutations, it's not routinely required for diagnosis. The direct Coombs test is negative in hereditary spherocytosis and is used to rule out immune-mediated hemolysis. Here's another case scenario. A 7-year-old with known hereditary spherocytosis presents with sudden worsening anemia, fatigue, and fever. Complete blood count shows pancytopenia. What is the most likely cause? A. Hypersplenism, B. Parvovirus B19 infection, C. Folate deficiency, or D. Autoimmune hemolysis? The correct answer is B. Parvovirus B19 infection is the most common cause of aplastic crisis in patients with hereditary spherocytosis. This virus temporarily suppresses erythropoiesis by infecting erythroid precursors in the bone marrow, leading to severe anemia and sometimes pancytopenia. In patients with chronic hemolytic disorders, who depend on increased erythropoiesis to maintain hemoglobin levels, this can precipitate a rapid drop in hemoglobin. Diagnosis is confirmed by Parvovirus B19 serology. This complication requires close monitoring and may necessitate transfusion support. Let's discuss management options for hereditary spherocytosis. Which treatment is the mainstay of long-term management for moderate to severe hereditary spherocytosis? A. Regular blood transfusions, B. Iron chelation therapy, C. Splenectomy, or D. Corticosteroids? The correct answer is C. Splenectomy remains the definitive treatment for moderate to severe hereditary spherocytosis as it eliminates the primary site of premature red cell destruction. This procedure significantly reduces hemolysis, improves anemia, and decreases the need for transfusions. However, it's typically delayed until at least 5 to 6 years of age due to the increased risk of severe infections in young children. Partial splenectomy may be considered to balance infection risk with hematologic improvement. Splenectomy doesn't correct the membrane defect, but it does extend red cell survival significantly. Considering post-splenectomy care, which of the following is most important in the long-term care of patients with hereditary spherocytosis who have undergone splenectomy? A. Lifelong antibiotic prophylaxis. B. Appropriate immunizations and infection precautions. C. Regular blood transfusions. Or D. Daily corticosteroid therapy. The correct answer is B. Appropriate immunizations and infection precautions are crucial for post-splenectomy patients due to their increased susceptibility to encapsulated organisms. Vaccinations against Streptococcus pneumoniae, Neisseria meningitidis, and Haemophilus influenza type B should be administered before splenectomy and boosters given according to guidelines. Patients should be educated about the risk of overwhelming post-splenectomy infection and the need to seek immediate medical attention for fevers. While antibiotic prophylaxis is recommended for children for at least 1 to 2 years post-splenectomy, lifelong prophylaxis is not universally required for all patients. Here's a case about complications. A 14-year-old with hereditary spherocytosis presents with right upper quadrant pain, nausea, and vomiting. Laboratory studies show elevated direct bilirubin and transaminases. What is the most likely diagnosis? A. Viral hepatitis. B. Cholelithiasis with biliary obstruction. C. Splenic infarction. Or D. Pancreatitis. The correct answer is B. Patients with hereditary spherocytosis have chronic hemolysis leading to increased bilirubin production and excretion, predisposing them to gallstone formation. By adulthood, up to 50% of patients develop gallstones. This patient's presentation with right upper quadrant pain and elevated direct bilirubin suggests cholelithiasis with biliary obstruction. Abdominal ultrasound would confirm the diagnosis. In patients undergoing splenectomy, concomitant cholecystectomy should be considered if gallstones are present. Viral hepatitis typically presents with more significant transaminase elevations, while splenic infarction would cause left-sided pain. Let's discuss nutritional considerations. Which nutritional supplement is most important to consider in patients with hereditary spherocytosis? A. Iron. B. Vitamin B12. C. Folic acid. Or D. Vitamin E. The correct answer is C. Folic acid supplementation is important in hereditary spherocytosis due to increased erythropoiesis, which accelerates folate utilization. Daily folic acid supplements help maintain adequate production of new red blood cells. In contrast, iron supplementation is generally avoided unless there is documented iron deficiency, as patients with chronic hemolysis often develop iron overload. Vitamin B12 deficiency is not specifically associated with hereditary spherocytosis, and while vitamin E has antioxidant properties, it is not routinely recommended for these patients. Here's a case about crisis management. An 8-year-old with hereditary spherocytosis presents with severe anemia, fatigue, and confirmed Parvovirus B19 infection. What is the most appropriate initial management? A. Immediate splenectomy. B. Red blood cell transfusion. C. Intravenous immunoglobulin. Or D. High-dose corticosteroids. The correct answer is B. Red blood cell transfusion is the mainstay of treatment for parvovirus-induced aplastic crisis in hereditary spherocytosis. Transfusions provide temporary support until erythropoiesis recovers, which typically occurs within 7 to 10 days. Close monitoring is essential, and hospitalization may be required for severe cases. Immediate splenectomy is not indicated during an acute crisis. Intravenous immunoglobulin may be considered in immunocompromised patients with chronic parvovirus infection, but is not routine first-line therapy for immunocompetent patients. Corticosteroids have no role in the management of parvovirus-induced aplastic crisis. Let's discuss genetic counseling. A 25-year-old woman with hereditary spherocytosis is planning pregnancy. Her condition follows autosomal dominant inheritance. What is the risk of her child being affected? A. 0%, B. 25%, C. 50%, or D. 100%. The correct answer is C. In autosomal dominant conditions like most cases of hereditary spherocytosis, each child has a 50% chance of inheriting the disease-causing mutation. Genetic counseling is recommended for affected individuals planning a family. It's important to note that the severity can vary significantly within families due to variable expressivity. Prenatal diagnosis is technically possible but rarely performed due to the generally manageable nature of the condition. If both parents have autosomal recessive forms of hereditary spherocytosis, the risk would be 25%, and if neither parent has the condition but had an affected child due to a new mutation, recurrence risk is low. Let's look at emerging therapies and research. Which of the following represents a promising area of research for potential future therapies in hereditary spherocytosis? A. JK2 inhibitors. B. Gene therapy targeting membrane protein expression. C. Chronic exchange transfusion. Or D. Tyrosine kinase inhibitors. The correct answer is B. Gene therapy targeting membrane protein expression represents a promising approach for future hereditary spherocytosis treatment, potentially addressing the fundamental defect by correcting or compensating for mutations in genes encoding red cell membrane proteins. This approach remains experimental but holds potential for definitive treatment. JK2 inhibitors are used in myeloproliferative disorders but have no role in hereditary spherocytosis. Chronic exchange transfusion is not appropriate for hereditary spherocytosis management and would lead to iron overload. Tyrosine kinase inhibitors target specific oncogenic pathways and are not relevant to membrane protein disorders. Let's consider special populations. A pregnant woman with mild hereditary spherocytosis who has not undergone splenectomy is being evaluated at 28 weeks gestation. Which of the following is most likely during her pregnancy? A. Significant worsening of anemia requiring transfusion. B. Development of severe preeclampsia. C. Minimal change or improvement in hemolysis. Or D. Increased risk of gestational diabetes. The correct answer is C. Pregnancy typically has minimal impact on the course of hereditary spherocytosis, and some patients may actually experience improvement due to the relative immunosuppressive state of pregnancy. However, adequate folate supplementation is crucial during pregnancy due to increased requirements from both pregnancy and chronic hemolysis. Women with hereditary spherocytosis who have undergone splenectomy generally tolerate pregnancy well. There is no specific association between hereditary spherocytosis and preeclampsia or gestational diabetes. Severe hemolytic crises during pregnancy are uncommon in mild hereditary spherocytosis. Let's discuss long-term complications. Which of the following is a potential long-term complication of hereditary spherocytosis in patients who have undergone splenectomy? A. Increased risk of thromboembolic events. B. Worsening hemolysis. C. Progressive renal failure. Or D. Secondary hypothyroidism. The correct answer is A. Patients who have undergone splenectomy have an increased risk of thromboembolic events, including venous thromboembolism and pulmonary embolism. This risk is attributed to persistently abnormal circulating red blood cells, elevated platelet counts, and alterations in coagulation factors. Patients should be counseled about this risk, especially in high-risk situations like pregnancy or surgery. In contrast, hemolysis typically improves significantly following splenectomy. Progressive renal failure and secondary hypothyroidism are not recognized complications of hereditary spherocytosis or splenectomy. Let's discuss differential diagnosis. A 3-year-old presents with mild anemia, splenomegaly, and indirect hyperbilirubinemia. Blood smear shows spherocytes. The direct Coombs test is positive. What is the most likely diagnosis? A. Hereditary spherocytosis. B. Autoimmune hemolytic anemia. C. G6PD deficiency. Or D. Pyruvate kinase deficiency. The correct answer is B. While the clinical presentation could be consistent with hereditary spherocytosis, the positive direct Coombs test strongly supports a diagnosis of autoimmune hemolytic anemia. The Coombs test detects antibodies or complement on red blood cell surfaces and is positive in immune-mediated hemolysis, but negative in hereditary spherocytosis. In autoimmune hemolytic anemia, Spherocytes form secondarily as a result of immune-mediated damage to the red cell membrane, while in hereditary spherocytosis, spherocytes result from an intrinsic membrane defect. G6PD deficiency and pyruvate kinase deficiency are other causes of hereditary hemolytic anemia, but typically don't present with spherocytes. Let's discuss ongoing monitoring. Which parameter is most important to monitor regularly in a child with hereditary spherocytosis who has not undergone splenectomy? A. Ferritin levels. B. Hemoglobin and hematocrit. C. Platelet count. Or D. Liver enzymes. The correct answer is B. Regular monitoring of hemoglobin and hematocrit is essential in children with hereditary spherocytosis to assess the severity of anemia, detect aplastic crises early, and guide management decisions, including the potential need for splenectomy. The frequency of monitoring should be individualized based on disease severity, typically ranging from every 3 to 6 months in stable patients. While ferritin may be monitored to assess for iron overload, particularly in transfusion-dependent patients, and liver enzymes and ultrasound may be performed to screen for gallstones in older children, hemoglobin monitoring remains the cornerstone of routine follow-up. In conclusion, hereditary spherocytosis is one of the most common hereditary hemolytic anemias, characterized by defects in red blood cell membrane proteins, particularly spectrin and ankyrin. It presents with variable severity of anemia, jaundice, splenomegaly, and an increased risk of gallstones. Diagnosis relies on family history, clinical features, laboratory testing including the EMA binding test, and characteristic blood smear findings. Management involves splenectomy for moderate to severe cases, appropriate vaccinations, and folic acid supplementation. Thank you for following the Pediatric Case Review channel. If you have any questions, please leave them in the comments section below, and don't forget to subscribe for more informative presentations on pediatric conditions.